Good evening, everyone. Thank you for tuning in to this evening's SSAT webinar on the General Surgery Certifying Examination Preparation, the mock oral scenario series. This is slated to go from 7 to 8 p.m. Eastern Time, and we'll try to stay on time. My name is Zivan Fong, and I'm a Surgical Oncology Fellow at Massachusetts General Hospital. My co-moderator is Maria Altieri, who is also the chair of our SSAT Resident and Fellows Education Committee. She's also the pioneer of SSAT's webinar programs and made it what it is today, so we have her to thank for being here today. We'll go through each of the mock examiner and the examinee introductions as we get through the mock scenarios. Real quickly, some house Zoom rules. Please mute your microphone when you're not speaking so we keep the background noise to the minimum. If you have any questions, please list them in the Q&A section at the bottom of the screen, and I will go through them at the end of the webinar. And for all of you who registered for this session, a copy of the webinar recording will be emailed to you. It is also posted on our SSAT Residence Corner website and uploaded to our SSAT YouTube channel. So please subscribe to our channel to receive updated postings from the account. And now I'm going to pass the mic to Maria, who will speak a little bit about the SSAT before we begin our webinar officially.
Thank you. Can you hear me okay? Great, thank you. So welcome everyone, thank you for joining. As Z mentioned, my name is Maria Altieri. I am MIS and bariatric surgeon at East Carolina University. So a little bit about SSAT. It's a great organization. It's the Society for Surgery of the Alimentary Tract. That's what the SSAT stands for. And it here is just a sample of what our categories for membership are. And I'll highly recommend that you guys join. It's very reasonably priced. Z, if you can just add to the next slide. The membership benefits. So you have a subscription to JOGS, which is the Journal of Gastrointestinal Surgery, which is also the journal for the society. Also, your membership leads to deeply discounted early bird registration to the meeting, which is the DDW, which is going to be usually coming up in 2022. I think it's in May. But to be determined the dates. Also, you can apply for awards, grants, scholarships, and traveling fellowships, leadership opportunities, as well as a lot of mentorship and sponsorship and other networking opportunities as well. So if you're interested, I would highly recommend that you join. Next slide. Oh, actually, that's it, right? There's one slide. Okay, great. So we'll start in with our first scenario, which I'll be presenting. And Dr. Douglas Cassidy, who is a PGY5 at MGH currently, and he is going to actually join as the fellow for at Washington University School of Medicine. Doug?
Thank you for having me.
Okay, are you ready?
I'm ready when you are.
Okay, and you're, let me know if you don't hear something or if you need me to repeat anything. Okay.
Yep.
Right. So you'll be doing a minimally invasive foregut case. So that's what we're going to start with. Okay. So you have a 65-year-old female who's presenting to your office with long-standing history of reflux, and she was recently diagnosed with a hiatal hernia. Prior to your presentation in your office, she has had all the preoperative studies, including an upper endoscopy, a GI study, and also an attempted manometry twice, but she wasn't able to tolerate that. So she's otherwise healthy. She doesn't have any previous surgeries. You examine her, you complete your H&P, which is essentially normal. And on your physical exam, her BMI is 27, otherwise non-contributory. And she's asking, what are the risks and benefits of surgery? She's in your office right now. What would you like to tell her?
So I would counsel her about doing a hiatal hernia repair and fundoplication, and that the benefits long-term is, absence of a need for a PPI for, for the rest of her life. So a cost benefit by avoidance of long-term PPI use, as well as the complications of long-term PPI use as well. I would discuss the risks and benefits of the surgery, including the immediate post-operative risks, such as any sort of injury to the esophagus or stomach, a wrap that's too tight, or any damage to the spleen or other surrounding structures. And then long-term complications, which could be failure of the wrap, a need for revision, and then complications such as gas bloat syndrome or PO intolerance to certain foods.
Okay. And what kind of wrap are you going to recommend for her?
Since we couldn't establish if she doesn't have any preoperative dysmotility, I would probably proceed with a partial wrap. So in this case, a toupee 270-degree posterior fundoplication.
Okay. So now you're in the operating room. You already prepped her, draped her. She received antibiotics and she has a Foley, etc. Can you describe briefly your procedure? How are you going to do, by the way, lap or open?
I'm going to do this laparoscopic. I'm going to have the patient supine in a split leg position in steep reverse Trendelenburg. I'll establish pneumoperitoneum with a Vera's needle at Palmer's point, and then place 5 ports, one camera port under optical viewing about 15 centimeters or less below the sternum, and then 4 additional ports, right-sided lateral port to place my liver retractor, 2 kind of mid-clavicular subcostal ports, working ports, and then an assistant port, the left lateral side. From there, I'll start at the gastrohepatic ligament at pars flaccida, and I'll open up the avascular space, make sure to avoid any anomalous hepatic arterial branches like accessory or replace left hepatic, and then be able to march my way up towards the crura to isolate the right crus. I'll dissect the phrenosophageal membrane and separate the esophagus from the crus, and then circumferentially mobilize the esophagus and develop that plane between the crus and the esophagus. If there's any hiatal hernia or paraesophageal hernia, I will perform a mediastinal dissection in order to reduce the hernia and be able to obtain enough intra-abdominal esophageal length, approximately 3 to 4 centimeters. At this point, I'd also mobilize the fundus of the stomach by dividing the short gastric vessels as well. If I've had enough intra-abdominal length, after reduction of the hernia, I'll place a Penrose in order to help provide some retraction, and then do a posterior cruroplasty with an absorbable suture. Once that's done, and if I'm happy with my cruroplasty, I'll perform a floppy 270-degree toupee fundoplication over a 54 French bougie.
Okay, and do you ask the resident to place the bougie, or do you ask anesthesia to place the bougie?
I can have the resident place the bougie.
Okay, so the bougie is coming down, you said the 54, and suddenly you actually see the tip of the bougie through your esophagus. What are you gonna do?
So if there's an esophageal injury, what I'll do is I will extend a myotomy in order to see the extent of the mucosal injury. And what we'll do is repair the esophageal injury in 2 layers, use an absorbable suture for the mucosa, and then a non-absorbable suture for the muscle layer. And then we'll have to, or I'll attempt to take my fundoplication and use that around the esophagus at the site of the injury to help provide some additional coverage.
Okay, so would you like to do a door fundoplication basically?
I would, yeah, do a door fundoplication at that point.
Okay, so let's say that you were doing your dissection and you noticed that the anterior vagus, you actually have gone through, you transected it. And the posterior vagus, you can't really, you can't find it. What are you gonna do?
So at this point, I'd worry about gastric emptying for this patient. I would probably proceed with my procedure and complete it, but know that there's a risk that this patient might have gastric emptying issues, and I don't think at that point I would do a pyloromyotomy or any sort of emptying procedure.
Okay. And after the surgery, would you let the patient know about this, or?
Yes, if they're at a higher risk, that we could only identify that there's an injury to the vagus, but we couldn't identify a posterior vagus. So I'm unsure if there's a complete truncal vagotomy or not that was performed.
Okay. So let's say that you were doing your dissection and you're trying to reapproximate your crura. However, you can't really bring that together. What are you going to do?
If the crura cannot come together, I'll place like a U-shaped biological mesh in order to provide additional coverage.
Okay. And your hospital, unfortunately, doesn't have a biologic mesh.
Then I can use a permanent mesh and fashion it in a similar manner.
Okay, a permanent mesh, like a synthetic mesh?
Like a polypropylene mesh.
Okay. And what are some of the risks of that?
There's always a risk of erosion, as well as always, if we're using mesh to begin with, always failure of the closure of the crura and reherniation and failure of the wrap.
Okay. So everything actually goes well, and none of these complications actually happen during the procedure. So the next morning, the patient is actually tachycardic. You notice that she was tachycardic overnight, and she's febrile as well. What are you going to do?
If it's post-operative day one and the patient's febrile and tachycardic, I would do just a brief, a quick exam, and if there's any concern, return to the operating room for evaluate for a potential leak.
Okay. How are you? You're just going to bring her to the operating room, or are you going to do like a?
I'll do a swallow, a gastrograph and swallow to evaluate for a leak.
Okay, great. Thank you. What did you think?
I thought it was fine. It was right to the operating room, and the workup was given to me. So I didn't get to touch on any of that. I kind of felt like we jumped right into things. I wasn't sure about if I should do an emptying procedure if I know one vagus is injured and I can't identify the other one. So I was kind of curious about that, and I think I hedged a little bit on seeing how the patient does. And then I wasn't, I'm used to using a biologic mesh, and I wasn't sure, about what I would choose for, a permanent mesh for coverage as well.
Yeah, no, I think you did well in terms of how you went through the problem. Like sometimes they'll just throw you into the OR and or like ask you to do like risks and benefits and not even like go through the workup. And then you have to just kind of think about like, what are the risks and benefits of this procedure? And as usual, like it's going to be like the bleeding, infection, damage to surrounding tissues, and some stuff about like, specific to the procedure. And you mentioned, like most of them. I gave you the bougie injury. I gave you these are like tough things. Usually they give you something easier, I think. And things that like I've read it from like books, you have the crura can be approximated, or the other thing that usually is the pleural injury, which you use the red rubber catheter, and then you ask anesthesia to give a couple of breaths. So I was trying to give you something that they're not gonna, you haven't like read about, to just see how you're going to react. For the procedure itself, and I'll just recommend for everybody to just have that down. You need like 5 or 6 steps. Don't take too much time about position. Like you can shortly mention about like positioning, and don't talk about like, like step-by-step little things, but just have like the 5 to 6 steps that are important. And for hiatal hernia repair would be dissection, like reduction of the sac, identifying your posterior vagus nerves, then the 2 to 3 centimeter intra-abdominal length, the short gastric, and then the wrap, right? And then you're going to do the bougie. And then that's why I wanted you to see what you're going to say about the bougie. So you did that perfectly. You handled that fine. If you have some form of unexpected finding or complication during the operating room, I would just shortly say that I'm going to disclose this to the patient. I'm going to make sure that they're aware of it. and then we can follow. That's perfectly fine. I mean, I think I've never had that happen to me before, but it's something that, you know, you always kind of worry about, that it's something like this can happen. And they just want to see that, to make sure that you're a safe surgeon. You're not going to do something that you've never done before, and you're not going to, you know, make up some stuff and start doing things that you haven't actually consented for, or at least you're going to discuss it with a member or something, and that's perfectly fine. Let me see. And then, you know, like they can ask you for like the pleural injury I mentioned, the short gastric injury you can have, the defect, like what would you do like if the defect is too large? Yeah, you're going to try to do a biologic mesh. You can approximate that, or you can also do a relaxing incision, and that's fine as well. I wouldn't say synthetic mesh on the boards, just because people do it, but just because of the risk of the erosion, I wouldn't say it. And then the next day, so anytime, I mean, you could have done everything perfect, and then they're going to throw you with a complication of the next day. What's going to happen? And you want to just kind of like go there and be like, okay, I'm going to go and examine the patient, examine the wounds, because it can be some form of an infection, and then make sure they have 2 large bore IVs. I'm concerned, my main concern is this, but I'm just going to just make sure that all the other ones are kind of check marked as well. So, but overall, great job. So congrats, you'll be fine.
you.
And if anybody has anything else, if they want to point it out in the chat, that's fine.
Well, thanks, Dr. Altieri and Dr. Cassidy. That was the MIS foregut surgery case scenario. Next up, we have the pediatric surgery case scenario, and we have Dr. Rohini Olsen as our mock examiner from East Carolina University, and Dr. Kristen G from UT Southwestern University as our mock examinee.
All right, we'll get started. So I'm going to turn on my timer to keep us on track. Okay, so Dr. G, you are on call, and the ER calls you in a bit of a panic. They have a 3-year-old female that they are concerned has peritonitis, and they'd like you to come evaluate her. So how would you like to evaluate this patient?
Okay, so the first thing I'm going to do is go down and see the baby in the ER. When I walk in the room, I want to take a look at the vitals monitor that the child is hooked up to. And then I would start with a quick history and physical. How long has the child been sick? What are the symptoms? Any past medical or surgical history, and then a physical exam.
So you notice that the heart rate's 145 when you walk into the room. The nurse tells you the temperature is 39.1. Blood pressure is 95/65. Respiratory rates 28, and SATs are 99% on room air. The parents tell you that the child has been sick for a few days. They think 3 or 4 days, just hasn't been eating well, has just been fussy. They thought the child was constipated. But then today the child had a fever to 39.5 at home and had a massive emesis and has been retching since then. Child is otherwise healthy, was born full term, no prenatal complications, and vaccines are up to date, no surgical history that's relevant.
Okay, and on my physical exam, what do I see?
So on exam, she's very fussy and has flushed cheeks, doesn't like you coming close to her to examine her. Belly seems full, and she's just bearing down and crying anytime you get close to her. She's just miserable, snotty, and bears down, so her entire abdomen feels firm when you try to examine her.
Okay, and do I notice, does the child have any hernias, inguinal hernias, and then a normal perineal exam and a normal, midline patent anus? I assume for a 3-year-old, yes, but.
Yeah, everything else is normal.
Okay, so I'd like to send off a set of labs, just a CMP and a CBC, and in the meantime, I would like to do a 20 cc per kilo NS bolus, and the other clarifying point I would like to know is whether or not the child's emesis has been bilious or not.
Yeah, parents tell you that the emesis has been bilious. They feel like she hasn't peed very much today, and that her energy level's been down. They also comment on one episode of diarrhea that was quite significant today.
Okay, so for bilious emesis and this physical exam, I am concerned for a malrotation volvulus, so I'd like to rule that out first. And given that the child doesn't have overt peritonitis on exam, I would like to get an upper GI while the child is getting a bolus.
Okay, and then the parents ask you what else you think may be going on. What else is in your differential?
So other things in my differential would be an intussusception, appendicitis, I think those are probably my top three things. And, you know, once we get the upper GI and see what's going on there, we could move on with other imaging from there.
Okay, so the radiologist, this is actually 2 a.m, says, do you need them to come in right now?
Yes.
Okay, so they come in, they do the study, and indeed there's no signs of malrotation. The child is able to keep down enough contrast.
Okay, excellent. And how have my vital signs improved since the baby got a bolus?
Your heart rate has come down a little bit to the 130s, and the child has had a wet diaper.
Okay, then I would like to proceed with doing an abdominal evaluate for appendicitis versus an intussusception.
Okay, so you get an abdominal ultrasound and you indeed see that there's a 1 centimeter tubular structure that's dilated and non-compressible, and there's associated free fluid. The parents ask you what you think the diagnosis is and what the next steps should be.
So the diagnosis is likely appendicitis. The next steps I'd like to take is giving the child Rocephin flagyl and then scheduling them to go to the operating room for a laparoscopic appendectomy.
Okay, they ask you if you think that the appendix is perforated or not.
So, you know, I don't usually like to say until after the OR. I think most likely yes, given how the child looks and that there's free fluid on the ultrasound, but truly that's something that we can't say until after we get out of the operating room.
Okay, and they ask you, you know, they've heard that with perforated appendicitis, people end up getting drains and don't have surgery right away. So they're wondering, you know, why not go down that route? Does the child have to have surgery? Is that going to set her back more?
So I think that since there's no obvious abscess on the ultrasound, just free fluid, and she's tachycardic with abdominal pain, the more beneficial thing to do would be to go to the operating room rather than to try and place a drain at a later time.
Okay, and then tell me what you plan to do in the operating room.
So I would, you know, make sure that the child has urinated prior to going to the operating room so that I don't have to place a Foley. I would place 3 trocars, a 12 at the umbilicus, and then 2 5s, 1 in the left lower quadrant and 1 in the suprapubic, and then I would put a camera in and see what's going on.
Yeah, for laparoscopy in this child, in the small child, what are some things that you would do differently relative to laparoscopy in an adult?
So for a small child, I would never use a varus. I would always, you know, get in open at the umbilicus, and, you know, I would start there.
Okay, any other changes for your instrumentation or your pressures?
For a 3-year-old, I would use lower pressures, probably no higher than 10 or 12.
Okay, all right. So you get in and it turns out that she has probably an associated ileus with this. You see pus, but you've got dilated loops of bowel everywhere, and it's really hard for you to identify the appendix to get adequate visualization of the right lower quadrant. What would you do?
Okay, if I don't feel like I'm making safe progress laparoscopically, then I would convert to open.
Okay. So you convert to open, you perform an appendectomy, you wash out a fair amount of pus from the abdomen, you close. Post-operatively, you're now 4 days into your recovery, and the child continues to have high NG outputs and still has a distended abdomen. What's your assessment of what may be going on?
Yeah, so I would tell the parents that for kids with bad perforated appendicitis, a prolonged ileus is extremely common. I would also tell them that we can expect that it would take her, you know, quite some time to get back to her normal eating and normal stooling before she feels better. I would keep her on IV antibiotics for the time being, and I would keep her NG tube in and just wait and see how she does. Okay,
and are you going to keep her on IV fluids or anything else for her?
Yes, so on post-op day 4, I would have her on IV fluids, probably D5 half NS with KCL. If we started getting closer to day 6 or 7, I would talk to the parents about starting TPN.
Okay, so day 7, you start TPN, no progress. She's now got a fever. What's next?
So 7 days post-op from a perforated appendicitis with a fever, I would do a repeat abdominal ultrasound to look for an abscess.
Okay, very good. So now let's backtrack and let's say that we're in the ER and the same patient's ultrasound actually showed you that there is indeed an ileocolic intussusception. How would you manage that?
So for this patient, I would talk to my radiology colleagues about performing a intussusception reduction, either with air contrast or barium, but most likely air contrast.
Okay, and you're there, they're doing the air contrast reduction, and the radiologist is concerned because all of a sudden there's massive pneumoperitoneum. They're concerned they have perforated during their air enema. What would you do?
Okay, so I would like to obviously be there while they're doing this air enema, look at the immediate last image that they have, and if I agree that there's massive pneumoperitoneum, I would take an angiocath needle and just place it through the anterior abdominal wall to evacuate out the air to make sure that the venous return is okay and that we don't lose our cardiac function. And then I would take the patient to the operating room.
Okay, very good. Let's end scenario there so we have time for discussion. So I thought you did a really nice job. You tell me, how did it go? Any areas that were particularly challenging?
I thought it went okay. I definitely, I think, thought you were going to take me down a malrotation volvulus pathway. And so my brain kind of shorted out a little when I realized that's not where we were going, and just kind of had to backtrack in my mind. So that was good practice for me to try to remember not to do that.
Yeah, I mean, I think this child has, a pretty broad differential, and you're absolutely right to be concerned about malrotation with volvulus with a bilious emesis, but perforated appendicitis, perforated Meckel's, an ileocolic intussusception, or even a terrible gastroenteritis can really all look like this in this age group. So you were right to focus on the initial resuscitation, and you were quick to assess how ill the child was. I think to highlight some of the testable points, you knew what volume to give, what fluid to give, so 20 cc's per kilo of normal saline. And you prioritized the testing appropriately with the upper GI followed by the abdominal ultrasound. In terms of the pediatric laparoscopy, I think that's another testable point that you answered nicely. Very clear about not using a varus needle and using an open technique to access the abdomen. You could also point out that you would use shorter trocars and shorter instruments, and recognize that you may not have enough room and need to convert to open, which may well happen. They could potentially ask you about staple loads if you're going to use shorter staple loads. I would gauge that based on the amount of edema in the tissue. It's not mandatory that every 3-year-old needs short staple loads, but something to consider. And regarding the post-op care, also good that you recognize that the patient is prone to having prolonged ileus and needing TPN and supportive cares for a prolonged period of time. I think a lot of times people panic when they get a child, but just recognizing some of the basic principles of general surgery to remain calm and follow the same thought process is helpful. And then the last scenario, the main teaching point I wanted to get across was what you did appropriately, which was to decompress the tension pneumoperitoneum that developed, so that angiocath above the umbilicus in the anterior abdominal wall is where you'd want to go. That's likely where the air would have accumulated in a supine patient. I thought all in all, that was a really good job, and you highlighted some key testable points.
Thank you.
Thanks, Dr. Olson and Dr. G. That was a great pediatric surgery multi-oral case scenario. We're going to move on to our third case scenario, which is the trauma critical care surgery case scenario. Our mock examiner is going to be Dr. William Wood from Washington Township Medical Foundation. And our mock examinee is going to be Dr. Luis Tavares from UC Southwestern University as well.
Good evening, Dr. Tavares. I'm William Wood. I'm a surgeon, and I'll be giving your mock oral exam today. Welcome.
Yes, sir. Nice meeting you.
Just think of us as just two colleagues having a nice discussion about anything you would typically do to manage your patients. No surprises.
Great, thank you.
You're on duty at your local hospital when you get a call from the recovery room because your partner operated on a 50-year-old man today. He had a lap-assisted left partial colectomy with anastomosis. He's a 50-year-old man with a previous history of hypertension for which he takes hydrochlorothiazide and no past surgical history. He is a former smoker, quitting 3 months ago, and he's 1 hour post-op in the recovery room, and you're getting a call for hypotension. The nurses tell you his current vital signs are 98.9, heart rate 110, blood pressure 90/50, respiratory rate of 18, and O2 sat of 98% on 2 liters nasal cannula. How do you wish to proceed?
So I will go down to PACU and start by getting a little information from either the nurses or the operative surgeon, the reasons for the surgery, if it was a benign disease or the patient had any infection at that time.
Sure, so you get a hold of the operative report, and a lap-assisted left partial colectomy was done. This was for adenocarcinoma noted to be at the splenic flexure. The colonoscopy reported grade 2 disease, and the metastatic workup was normal, meaning no metastatic disease. The preoperative CEA was 1.0, and the hemoglobin was 12.5, platelets were 330. The rest of the operative report remarks that the case duration was 4 hours, that they mobilized the splenic flexure as well as the transverse colon, and a stapled anastomosis was performed. EBL was noted to be 200 milliliters. IV fluids given in the form of crystalloid only was 1 liter. And the anesthesiologist mentioned that there was phenylephrine given towards the end of the case for blood pressure changes. A drain was left intra-abdominally and a Foley catheter, for which the nurses report no urine output over the last hour. No mention of identifying the ureters.
What's the quality of the drain?
So you want to examine the patient?
Yes, sir.
So you examine the patient, and his vitals are what was given before: 98.9, 110, 90/50, 18, 98% on 2 liters nasal cannula. He appears disoriented. His incisions are clean, dry, and intact. There's no crepitus or bullae. His drain appears to be serosanguinous. There's 20 cc's in the bulb, and that's all that's recorded. His abdomen is mildly distended, and there's no peritonitis that you can discern.
Good. I would start making sure the patient has adequate cardiac monitoring. Make sure he is connected to the monitor and place EKG leads. Starting him on some. He was on 2 liters of nasal cannula, so I'm just gonna monitor his pulse oximetry, and I would start him with a bolus of IV fluids, LR, 30 cc's per kilo, and start sending some labs. I'm interested in hemoglobin, platelets, coagulation studies, and basic metabolic panel, specifically creatinine.
A liter bolus of crystalloid is given. Repeat vitals are done. The vitals are 98.9, heart rate 110, blood pressure 90/50, respiratory rate of 18, 98% on 4 liters nasal cannula after you increased it. His labs come back with a hemoglobin of 10.5, white count of 13.0, platelets of 300. Is there any other thing you were asking for?
Yeah, with my labs, I would also send for troponins and send for an EKG at the same time.
Your troponin is measured as less than 0.01. Your EKG shows sinus tachycardia, no signs of ischemia.
Okay, at this point, I would give the patient another liter bolus, and if he would not respond to that, then I would start him on vasopressors, probably levofed.
Okay, you do 1 more liter of crystalloid, and his hemodynamics are unchanged. His heart rate is 110. His blood pressure is 90/50.
Okay, so I'm sorry if I missed this. What's his auscultation of the chest?
It's difficult to tell. Maybe there's less breath sounds on the left versus right.
Okay, with the workup, I will get a stat chest x-ray. I'm concerned that since there was some dissection on the splenic flexure, there's a possibility of an pneumothorax on this side.
The bedside chest x-ray comes around, and there's no gap between the apex to cupula bilaterally.
Okay, in what position was the patient placed?
He was semi-upright.
Okay. So at this point, I would probably start the patient in vasopressors for undifferentiated shock. And I would plan for an echo as soon as possible. I would probably, as long as the patient's stable, I will try to move him to the ICU.
Which vasopressor would you use?
I would start with norepinephrine.
And at what dose?
0.01 per kilo.
Okay, that's started, and you recheck his vital signs, and his heart rate is 110, blood pressure 90/50, and his oxygenation is 98% on 4 liters nasal cannula.
At this point, I haven't obtained an ABG. I think I want to make sure he's not acidotic and he is not getting worse from a respiratory status. So once he gets to the ICU, I would then add a lactate and an ABG.
Okay, he's transferred to the intensive care unit. An ABG shows a pH of 7.35 and a base excess of -8.
-8. I would, while he's still on vasopressors and has received 2 liters of LR, has he started to make any urine at all?
He's made 5 cc's of urine output since you saw him.
Okay. Let's try flushing the Foley, make sure there are no kinks and it's flushing well. And I want to make sure his abdomen continues to be soft.
60 cc's are placed of normal saline and 60 cc's return.
Okay.
The abdomen remains mildly distended, no signs of peritonitis.
No signs of peritonitis. Okay, so that's reassuring. The incisions are not do not look infected. Just to recap, he continues to be hypotensive and tachycardic. And were we able to obtain that echocardiogram?
The echo shows no right heart strain. EF is 60%.
Okay. So in a patient with cancer.
Let's stop there. Thank you for your time.
Thank you, sir.
So that was over 7 minutes. So they'll cut you off because there'll be 4 scenarios per room. So too much time on that one. So this is a case of shock. And it's post-op shock specifically, which is a very commonly tested scenario for the oral boards. Shock can come in many forms, including traumatic shock, cardiogenic, distributive shock, which this was leading towards, or it could be also neurogenic shock or some of the rare ones such as endocrine system malfunction or not working correctly. So in the case of shock, it's one of those ones where the differential is very wide and it can go in any direction. So it's a bit of a game between the examiner and examinee for this type of scenario where depending on your answer, I'm going to give you something else. So for the case of shock and going through your differential, it has to be fast. And you are allowed to say it up front. You almost did, you kind of alluded to it, say, this sounds like shock. And then you say, I need to rule out cardiogenic, hemorrhagic, pneumohemothorax, heart attack, heart failure, abdominal compartment syndrome, and then any other rare ones such as septic shock or endocrine. So it's a matter of quickly getting through a differential and then kind of having a feedback kind of game with this examiner because they want to know how you manage shock. And then we can go into the specifics of which vasopressin to use, and then which cardiac monitoring device you want to use, Vigileo, or even a pulmonary catheter if you really wanted to go there. And you have to demonstrate your knowledge of those numbers. So in the cases of shock, you have to know it down cold. And the distribution of which one is going to be, well, they're all equal in this case because the examiner is going to do whatever you don't say. All right. Otherwise, good job. I like your flow. I like your speech, very calm. And I liked how you were thinking ahead, but just got to get to it a little bit faster. Just ran out of time.
Thank you, sir. Thank you, sir.
Welcome.
Thanks, Dr. Wood and Dr. Tavares. And just like Michael Jordan said, I never lost a game. I just ran out of time. Moving on to our next mock case scenario of vascular surgery, we have Dr. Sarah Deary from Maine Medical Center as our mock examiner. And our mock examinee is going to be Dr. Sri Khanna from McGill University.
All right. Thanks, Dr. Khanna, for listening to this. We will go ahead and get started. So a 64-year-old male comes into the emergency department. You performed an aortobifemoral bypass on him with bifurcated dacron 3 months ago. His past medical history, and that was done for lifestyle limiting claudication. His medical history is otherwise notable for insulin-dependent diabetes and hypertension on 2 agents. He has no other surgical history besides the aortobifemoral bypass that you recently performed. And he's a prior smoker, but has subsequently has not been smoking. On exam, when you go to see him, he has a fever of he presents to the emergency department with the chief complaint of having now some drainage from his left groin incision. But when you talk to him about his other complaints, he says that he's had a couple weeks of sort of low-grade fevers and chills subjectively, some malaise, and he's lost about 5 pounds of weight. Your exam is that he has a fever or a temperature of 100.5. He has a heart rate of 90. His blood pressure is 160/90. He has a well-healed midline and right groin incision. The left groin has a small area of dehiscence, and when you probe it, you can get some purulent fluid out. And he has triphasic signals in both feet.
So this is a patient who's currently stable hemodynamically. The patient does not have any evidence of acute limb ischemia, and the patient is showing signs of sepsis. At this point, I would like to start the patient on broad spectrum antibiotics initially. I would also want to do, in addition to that history and physical, a DRE and get a history of if the patient's had any melena or any bright red bleeding per rectum. I would do full labs, including CBC, Chem7, COAG, BBG, and also blood cultures, stool cultures, and ESR CRP. I would get a CAT scan with contrast thorax abdo-pelvis as well.
Okay, so you get your full set of labs. The white count is 15, ESR is 80, CRP is 15, his creatinine is 1.5, his baseline is less than 1. He has an albumin of 2.7. Otherwise, full chemistry and coags panels are all unremarkable. His digital rectal exam is negative for any occult blood, and he denies any symptoms of hematochezia or hematemesis or any other symptoms like that. Oh, and your CAT scan. So after you do all that, you proceed with getting your CTA. And on the CTA, you see that the graft is patent. On the left groin, there's about a 1 centimeter pseudoaneurysm at the common femoral artery anastomosis to the graft. There is a little bit of surrounding fluid and stranding that tracks up into the left pelvis, as well as some air. And you see some air that's surrounding the main body of the graft as well.
Okay, at this point, I'm concerned for a graft infection. Given the patient is stable, I would like to work him up further and see the extent of white blood cell intake or uptake using a white blood cells tagged scan, or I would also get a PET scan.
Okay, so you get that. It takes a few days to get that in your hospital, but it shows positive uptake in the left limb as well as up into the main body of the graft.
Okay. In this case, I would have to proceed with a total explant of the aorta bifem, and I would get an echo pre-operatively and an ECG as well to see if the patient would be able to tolerate proximal control with clamping.
So you get an echocardiogram, and he has a normal EF. It's pretty much a normal study.
Okay. Given that this is the left groin, and given that there's a previous operative field, I would take this patient in to do a retroperitoneal approach to an excision of the aortobifemoral graft with a counter right groin incision. And I would do in situ reconstruction with flap coverage of, with omental flap coverage of the main body, and also with sartorius flap coverage of the left groin.
Okay, so can you walk me through that? And what conduit you would use as well?
So first of all, I would make a left flank incision, depending on the aneurysm, depending on the extent of the disease here, I would go into the left rib space, extending from the left lateral margin of the rectus sheet. I would expose all 3 layers of the abdominal musculature, sweep the peritoneal medially, and expose the aortic and visceral vessels from the diaphragm down to the iliac bifurcation. I would also make, as I said, a counter incision on the right side to obtain control of the femoral vessels. I would proximally clamp infrarenally if I could, if there's still a neck. If not, I would consider doing suprarenal clamping. And I would get distal control via the right counter incision, and the left common iliac could be exposed through my retroperitoneal incision. The conduit of choice for me would be a rifampin-soaked Dacron or cryopreserved graft, whatever that's available in my institution. I would resect the main body and the aortobifemoral graft in totality. I would resect any other tissue in the retroperitoneum or pelvis or groin that appears infected to me. I would reconstruct the aorta with my in a configuration of either an redo aortobifem, but extend my left limb into the profunda and reimplant the SFA onto it. And I would get omental coverage of the aorta, the neo-aorta, and also cover the left limb with sartorius flap to protect the groin.
Okay, and what are you going to do with the right limb?
With the right limb, at this point, I would just re-anastomose it to the same distal target as the previous surgery.
Okay, and what if you see quite a bit of pus extending down towards the right groin when you go in for surgery?
In that case, it would change my operative management. I could do an aorto left, so I could do an aorto uni left femoral profunda bypass and a crossover bypass to the opposing right profunda. I apologize. Or I would extend both my limbs down to the profunda and reimplant the CFA bilaterally.
Okay. All right, I'm going to stop you. We're a little bit over 7 minutes. The vascular scenarios tend to go pretty quickly because there's a lot to say about the operations. You did a great job. Graft infections in general in vascular cases are very common on the Gen Surg boards. I had a graft infection case. I think the general gist of it is going through the workup. They usually give you a lot of the information before, so you can kind of jump straight into the workup. And in most things vascular, at some point, unless someone's unstable, you're going to need some sort of localization and imaging study, which is either going to be some sort of duplex ultrasonography or CAT scan like you obtained. And in this particular case, I wanted it to be something that clearly involved the main body of the graft and not just the limb, because if it's just the limb, you could talk about doing some sort of more of a graft salvage and just reconstructing, doing a retroperitoneal incision on the left and then doing a separate incision sort of laterally to cut down on the profunda and doing an interposition graft there, doing that reconstruction first in sort of a clean field, and then going in and resecting the infected issue, the resected area at the anastomosis. But I tried to give information that made it seem like the main body was infected. I think in those scenarios, if you're extending up into the main body, you're probably just going to go ahead and replace the entire thing, including the right limb as well, although you could potentially get away without doing that. I have been trained doing mostly retroperitoneal approach as well, but I think for the general surgery boards, it's often safer and easier to do transabdominal approaches, particularly when there's any concern that you're going to have to go into the right groin, which I sort of set you up for not having to do that. And I think the key points of that is just understanding, especially in someone that's unstable, how to get supraciliac control and how to get control of the infrarenal aorta afterwards. And so I'll just say, since we didn't really get into that, and this was a stable patient, that I think the important things to mention, and I know that Doug mentioned this in his case, getting this access, but for supraciliac control, you're going to mobilize the left lateral liver medially, and then you're going to get into the gastrohepatic ligament, watch out for any sort of accessory hepatic artery there, and divide the crus of the diaphragm. You're going to make sure you get the esophagus out of the way, clamp the supraceliac aorta with an aortic DeBakey cross clamp. And then in order to get down to the infrarenal segment, you're going to lift the transverse colon out of the body, move the small bowel to the right, and then mobilize the duodenum to the right off of the aorta. And at that point, you're going to see the left renal vein, which normally you don't have to take. You can normally pull it up and even get suprarenal control there, which is often necessary in these redo cases, especially if the anastomosis goes all the way up. So I think those are the sort of anatomic things that are important to get to. As far as conduit, I think an important thing in all of the boards is to say, this is what I'm going to do, and not say you could do this or this, because you need to just choose one thing that you're going to do. And you mentioned two things you could do, one being cryopreserved graft and one being rifampin soaked graft. An alternative would be neo-aortoiliac system or using autogenous femoral vein. If you're going to do that, you have to make sure that you get an ultrasound beforehand to ensure there's no DVT. And then the alternative is doing an extra anatomic reconstruction with axillofemoral bypass. So all of those things are options. And I think if you have an idea of what the different options are for conduit and reconstructions for these vascular graft cases, then you'll be able to get yourself out of anything. Also, don't forget to heparinize, and don't forget, just always in vascular, everything is all about proximal distal control. And don't find yourself in a scenario where you're cutting down on a groin pseudoaneurysm without having proximal control, because they'll just get you down to a terrible rabbit hole if you do that. I think that's it.
Thanks, Dr. Thierry and Dr. Khanna. That was a great vascular surgery case scenario. We're going to move on to our final case scenario, which is the endocrine surgery case. And our mock examiner is going to be Dr. Amin Madani from University Health Network in Toronto. Our mock examinee is going to be Dr. Catherine He from Brigham and Women's Hospital.
Thank you, Dr. Fong. And thank you for everybody for inviting me and for the examinees. Okay, let's switch to something more relaxing and cool, like endocrine. Are you ready to begin, Dr. He?
Fantastic, ready.
Okay, so you have a 45-year-old female who's referred to you to your outpatient clinic for a thyroid mass. Please describe your assessment.
So first, I'd like to start with a history and physical. On the history, I'd like to focus on any past history of neck radiation, any past cancers for the patient or past familial cancers like pancreas or pituitary or thyroid cancers. And for physical examination, I do a focused neck exploration, palpating for any masses as well as lymphadenopathy.
Okay, is there anything else you'd like to know on history?
I'd like to know how long they've had this mass and if there's any attendant symptoms such as dysphagia, odonophagia, or dysphonia.
So she's experienced this for the past 3 months. The mass has become more noticeable. Upon further history, you identified that she's had some more dysphagia as well, no dysphonia, and no dyspnea as well. She does not have any past history of radiation exposure or any other history of malignancy. On exam, she looks clinically well to you, and you can palpate a 2 centimeter mass on the left side of her thyroid and no cervical lymphadenopathy. Anything else you'd like to know?
The next thing I'd like to do is move forward with some laboratory and imaging. So for labs, I'd like to get a TSH, a basic metabolic panel, a PTH level. And then in terms of imaging, I'd start with a neck ultrasound of the thyroid and bilateral neck.
Okay, so you do a TSH, it's normal. You do your PTH level, that's normal. You do an ultrasound, which shows no cervical lymphadenopathy, but you identify 2 lesions, one on the left side, 2.5 centimeters, hypoechoic, well-circumscribed lesion, taller than wide with no calcifications. So that's 2.5 centimeters on the left side. And on top of that, there's another lesion on the right side that's 8 millimeters, hypoechoic, and no other features, well-circumscribed lesion.
Okay. Given that the TSH is normal, this makes it a little more concerning for malignancy. The features of a size greater than 1 millimeter, hypoechoic, and tall and wide are all also concerning for malignancy. At this point, I'd like to proceed with a fine needle aspiration of both sides.
Okay. So you do an Fna biopsy. On the right side, sorry, on the left side, it comes back as Bethesda 3, atypia of unknown significance. And on the right side for the 8 millimeter nodule, it comes back as benign cells identified.
For the right side, benign cells, that can usually move forward with, I would move forward with observation for that. But the Bethesda 3 follicular lesion of unknown significance, that's more concerning for cancer. At this point, I'd like to move forward with the repeat FNA of the left side.
Okay, you do a repeat FNA and comes back again as atypia of unknown significance.
Do I have access to Afirma or any other molecular testing?
No.
Okay. So at this point, I would think it's a high risk lesion. I'd like to proceed with a left lobectomy with permanent pathology.
Yeah, sorry, can you repeat that? My connection just broke. What would you like to do?
I consent and take the patient to the operating room for a left lobectomy.
Before you take them to the OR, the patient asks you, why do I need to have this lump removed, Dr. He? How would you like to describe your indications during your consent?
I'd say it's a very good question. There's a possibility that this lesion could represent thyroid cancer. The specific type of cancer would be potentially follicular cancer. Unfortunately, we need to see the entire architecture of the nodule to be able to determine if there's invasion, which would demonstrate cancer instead of a benign nodule. So we have to get the entire sample out and look at the capsule to determine whether or not this is cancer.
Okay, and if they ask you, what's my risk of having cancer, doctor?
For a follicular lesion of unknown significance, it's between 10 and 30%.
Okay. Any other investigations you want to do before surgery?
Given that this patient has this patient had neck surgery previously?
No.
Okay. Given that there's no prior history of neck surgery, I would not do any additional measures such as imaging of the vocal cords.
Okay. And okay, so describe your steps to a left hemithyroidectomy.
I would do a collar incision in a natural skin crease below the cricoid cartilage. I would incise through the platysma. I would lift up my subplatysmal flaps, identify the strap muscles, separate the strap muscles, and then develop my plane between the thyroid and the strap muscle. I'd start my dissection at the superior pole of the left thyroid and ligate the vascular bundle at the superior thyroid close to the thyroid to avoid damage to the superior laryngeal nerve. And then I'd proceed my dissection laterally, identify the recurrent laryngeal nerve and make sure to preserve it. Also identify the 2 parathyroid glands on the left side, preserve those. And then carry my dissection medially underneath the thyroid towards the ligament of Fary, and then transect at the isthmus.
Okay. What are some of the post-operative considerations for this patient?
So given that it's just a unilateral lobectomy, the risk of a hematoma is relatively lower. But in any sort of neck surgery, you're always concerned about postoperative bleeding and neck hematoma requiring emergent exploration. Another consideration you would have is damage to the recurrent laryngeal nerve. Unilateral recurrent laryngeal nerve damage would result in hoarseness of the voice. And then another consideration would be hypocalcemia, which would be, again, less likely because we have not touched the parathyroids on the other side.
Excellent. Any other medications you may potentially put the patient on postoperatively?
Some of the considerations you could do would be to start levothyroxine or calcium supplementation. I would start the patient on calcium supplementation and then check calcium and TSH about 4 to 6 weeks postoperatively.
Okay, we'll change the scenario a little bit. Let's assume you did a total thyroidectomy on the patient, and about an hour and a half postoperatively, you get called to the PACU because the patient's having difficulty breathing.
I would immediately assess the patient, look at the vitals, especially saturation, and also assess the quality of the patient's voice and their breathing.
Okay, so they're having difficulty breathing. Their SAT is in the low 90s. They're clearly struggling to take breaths, and they're having a significant stridor, and they can't really produce a lot of phonation.
And what is their neck exam?
It's not, you don't see a tense hematoma.
Okay. So, and this is after the total thyroidectomy and not the lobectomy, is that correct?
That's correct.
Okay. Here I'm concerned for bilateral recurrent laryngeal nerve injury. And at this point, the concern there is that the vocal cords have both adducted and the patient cannot breathe. So I would proceed with transfer to the operating room and consent the patient for emergent tracheostomy.
Okay.
If the patient appears stable for transfer. If they do not appear stable for transfer, I would do an emergent cricothyroidotomy.
Okay, well, based on that description of the patient setting in the 90s, significant stridor, what would you like to do?
I would like to do a bedside emergent cricothyroidotomy.
Okay, I'll stop right there.
Thank you.
Okay, so I guess I give you your feedback now. That was really great. Endocrine is a bit trickier because, especially with thyroid, parathyroid, adrenal, it's just, there's so many different signs and symptoms that you're going to encounter, and it can kind of get very complex. What I would do for your HPI is you want to break it down into sort of 3 categories. Number 1, I asked them about local regional symptoms. Are there any anatomical symptoms? And you did that really well. You asked about the 3 Ds: dysphonia, dysphagia, and dyspnea. You can also ask them if they're having choking sensation when they lay back. So number 1 is, do they have symptoms from the thyroid nodule? The second thing is you want to ask about, don't forget to ask about functional symptoms as well. And you can put that into one category. You don't have to go through a review of system. You can just say, I would do a full review of systems for look for signs and symptoms of hyper and hypothyroidism. Done. Bam, out of the way. And then the third thing that you want to ask for these endocrine cases is risk factors for thyroid cancer. And the big 2 are, number 1, radiation exposure, which you did great, and family history is the second one. So those are kind of the 3 main things that you want to ask on history physical, on history. And also don't forget to also ask about the other things like past medical history, medications, social history, allergies, all that stuff. And you can kind of rhyme that up in one sentence just to kind of make sure to cover all your bases. In terms of your investigations, that was phenomenal. The 2 main things are ultrasound and TSH, which you did. You don't need to do a PTH necessarily. I think your metabolic panel was fine. Check for the calcium and screen them for hyperparathyroidism, because you don't want to go back in the neck for that if they have that disease. So that was good. In terms of your investigations, so you typically don't want to biopsy, do an FNA on anything less than 1 centimeter. So anything less than 1 centimeter, doesn't matter how worrisome it looks like on ultrasound, it doesn't fit the criteria for surgery. So I would avoid doing that in your exam, and that's consistent with the ATA guidelines, the American Thyroid Association guidelines. So if you want to have a reference to look at the ATA guidelines for thyroid nodules. They're the most they're the sort of gold standard. For the left side, that was good. You got the FNA, and it came back as AUS, and then your decision was right to, you can either, basically you can offer the patient either to do a diagnostic lobectomy or to repeat the FNA biopsy or to observe it. And I think you're offering to repeat it is good. And that's what we do for indeterminate nodules oftentimes. The other thing though, for consenting for surgery, so just remember, there's 3 reasons why you would operate on a thyroid nodule. Number 1 is if they have symptoms of a goiter. So if they have dysphagia and whatnot, that number 1 is an indication. The second thing is if they have, if the risk of malignancy is high enough to warrant an operation. And in this case, after 2 AUS results, that would be one other reason to offer a diagnostic lobectomy. So you already have 2 reasons right there. The third reason would be for a hyperfunctional nodule. So those are sort of 3 categories where you would offer a thyroidectomy for. And so that I would say that in your when you're consenting a patient. And I think you said 10 to 30%. That was fairly close for the chance of malignancy for US. It's about 5 to 15%. Highly also dependent on which site you're at. So that was good. In terms of preoperative workup, you want to make sure to mention. So this is not like other cancers. You don't need to do CT chest, abdo-pelvis, but you need to have some kind of imaging for the neck. And just make sure on your ultrasound, you say, I want to evaluate the lymph nodes, the cervical lymph nodes on my ultrasound, or get a CT scan to evaluate the lymph nodes, because that will dictate your management. And then your steps of the operation were exactly bang on. Just a minor point, it's the external branch of the superior laryngeal nerve, just a very minor point there. And then what else? The other thing that I want to mention is at the end, when the patient did have a bilateral nerve injury, you caught up on that very well. The most important thing is to get an airway. I don't think, in that situation, the patient is not really safe for transfer to the OR, especially if they're about to close their airway. One of the things you can do is actually do a fiber optic laryngoscopy at the bedside. And that way you can evaluate the vocal cords, because I actually had a case like this, and it turned out, in my fellowship, and it wasn't actually, from the vocal cords. It actually was, they just had really bad asthma that was been poorly treated. So it's, you can avoid, doing something unnecessarily. And also, if you see that there's still a pinpoint hole that's available, you can actually use the fiber optic intubation to get control of the airway, and then do things under a more controlled setting. And the other things is always call for backup for, a senior anesthesiologist in your building to come help you. And this is where you really want to go into damage control and get all the available help around. So those are kind of my things that I would mention. Also, you don't need to put calcium, prescribed calcium post-op for someone with a hemithyroidectomy. The chance that they have hypocalcemia is 0%. Okay, that's all I got, but that was really phenomenal.
Thank you very much.
Oh, thanks, Dr. He and Dr. Madani, for closing us with a low-key endocrine case scenario. We had a question in the Q&A session from Michael asking that I was quite lost listening to the details of the graft excision and what to do with the limbs of the graft. Are we expected to know the details of these complex operations, and there are only a handful of core vascular operations in the SCORE curriculum? I'm reading this all out just for the recording, because I don't think the chat is available in the recording, just so if people are watching the recording of the Zoom, if they didn't make it. Dr. Tavares said that although not part of the core procedures, extra anatomical bypasses are part of the advanced procedures, usually means it's fair game, although not commonly asked. I did not get to Dr. Deary's paragraph, but maybe Dr. Deary can elaborate a little bit on her end.
Yeah, I was just going to say that I think that graft infections are, there's always one vascular scenario on the general surgery boards. And I think a graft infection scenario is a commonly tested topic because it can get at a lot of different issues. And a lot of the issues really is just the initial workup, and a lot of that was given to you in this scenario, but just getting resuscitating, starting empiric antibiotics, getting cultures of blood and fluid, making sure you get some sort of localized imaging study if the patient is stable, which is usually a CTA. The graft infection is probably more likely to be tested on a lower extremity graft, which can get at the femoral and potentially popliteal or other exposures, or just an isolated femoral limb of an irido bifemoral graft, in which case you can do a retroperitoneal exposure a couple centimeters above the inguinal ligament to get down on the external iliac artery to get proximal control. And I think that's a relatively common scenario, although the scenario usually is getting pretty close to 7 minutes by the time you start to have to describe the operative techniques in those cases. I do think that it's one of the advanced procedures, but an open transabdominal aortic aneurysm repair is a scenario. And that's the only reason really that I included the aortic part of the graft being infected, just to try to get at some of that as well. But a lot of the conduit use and things are not necessarily going to be tested. I do think it's important to know that you don't want to put more prosthetic graft into an infected field. You want to do something extra anatomic or stay out of that field, or do something non-prosthetic.
All right, I'm sorry we're a little bit over time, but before we end our session, I'm going to pass the mic over to LK, who has a few to say about our podcast. This will be really quick.
Sure. So thank you all for attending tonight's webinar. I wanted to alert everyone that the SSAT has a podcast series. It's streaming on your favorite podcast platform. We have over 14 destinations where you can access the SSAT sound bites. And this webinar will also be posted as an episode on the podcast. So if you were only able to make part of it and can't watch it necessarily as a webinar recording, which will all be available online, you can listen to it as a podcast episode as well.
And a reminder that this session is recorded and will be posted on the SSAT Residence Corner website for future viewing. And to close, I'd like to thank all our speakers and mock examinees who took the time out to be here today. It isn't easy volunteering to be a mock examinee in front of a national crowd, but you did it and all of you killed it. Specifically, I'd like to thank Maria Altieri, our community chair, for her leadership on our committee and leading the webinar efforts. But most importantly, we'd like to thank LK Coughlin, who's our Director of Administration, who does all the behind the scenes dirty work alone and somehow managed to keep every committee member in check, and this doesn't happen without her. So good luck on your boards, and thank you again everyone for tuning in, and good night.